Hello class. I'm just going to talk a little bit about our concept of comfort with our exemplar of acute and chronic pain. And I'm just going to go over the PowerPoint that's obviously downloaded in your Canvas course. Okay, so we'll talk about some of the important aspects of acute and chronic pain. We know that pain is a very unpleasant and highly personal type of experience. It can be either physical or emotional and may be imperceptible to others. And pain can be very devastating. It can consume all parts of a person's life. It can be both a sensory and emotional experience, and pain is whatever the client says it is. Exists whenever a client says it does. We as nurses cannot say, oh, you're really not feeling that pain. How can you be feeling that pain when you're laughing and you're talking on the phone? We would never say that to a patient. If they say they have a pain of 8 out of a pain scale of 10, then that's what they have. And we have to respect that when they give us that information. Again, when we assess pain, we are definitely finding out more information about that pain. Remember old cart and ice that we talked about from Nursing 100? Onset, location, duration, characteristics, aggravating factors, relieving factors, and treatment, and the impact on activities of daily living, coping factors, and emotional response. All from those acronyms of old cart and ice. And these are the intensities of those pain. It can be anywhere from mild, moderate, or severe. And when we use a pain scale of 0 to 10, 1 to 4 is mild, 5 to 6 is moderate, and 7 to 10 is severe. And we look at the quality of that pain, anywhere from stabbing, to burning, to itching, to tingling, to cold, cramping, ache, dull, tender, sensitive, shooting, numb, radiating, throbbing, and heaving. So many ways in which we can really hone in as to what kind of pain our patients are experiencing. This is a way in which we can kind of differentiate acute versus chronic. Acute is sudden onset, identifiable tissue injury, typical autonomic responses. Usually acute pain lasts for under 6 months or until that injury heals. And when we talk about acute pain, we can refer to 3 types of category. The first one is somatic, and this originates from nociceptors located in the skin and musculoskeletal tissues. It can be localized and it can be described as sharp. It can be accompanied by swelling, cramping, or bleeding, usually treated with mild analgesics. Example of this would be if you cut your finger. Say you're trying to prepare dinner one night and you cut your finger with a knife. That's an example of somatic pain. It's acute. It's only going to last until that area actually heals. The next one is visceral, and this has to do with internal body organs, lining of body cavities in the chest, abdomen, and pelvis. Can be described as a dull, deep, or aching. Can respond to inflammation, stretching, and ischemic changes rather than to lacerations. Manifest as radiating or referred pain. And usually with this type of pain, it's necessary for relief by opiate treatments. Example of visceral pain would be myocardial ischemia. Maybe someone has urinary colic that results from renal calculi or renal stones. The next one is referred pain, which is sensed in a region other than the site of the origin. Sometimes patients that are having a heart attack will start to have referred pain going down their shoulders, down their arms, maybe referring around to the back area. Patient that might have pancreatitis, nerve fibers that innervate the injured region, and nerve fibers from other regions of the body converge at the same level in the spinal cord. So that's what we mean by referred pain. And then of course in the next column we talk about chronic pain. And that's pain that lasts beyond the expected time of healing, usually for at least 6 months or longer. Pain can range from anywhere to mild to severe, and autonomic responses decrease over time as the body adapts to the persistent pain impulses. And chronic pain also has 3 categories. And many times with chronic pain, not always a known cause, and as I said before, you do adapt to some of these autonomic responses. The first type of categories is recurrent, intense episodes of pain interspersed with periods of no pain. An example of that might be someone that has and suffers from migraine headaches. The next one is chronic intractable benign pain, chronic pain that is always present. Intensity may vary, and that may be somebody that has chronic back pain. In chronic progressive pain, worsens over time. Somebody that has maybe a rheumatoid arthritis, somebody that has cancer, the pain gets worse, especially like if it would metastasize to the bone. Of course, the pain is going to become worse. Many conditions can cause chronic pain: arthritis, a cancerous tumor, which may cause nerve compression, visceral expansion, duct obstruction, or bone metastasis. Because tumors do produce biochemicals that stimulate pain, treatment can be obtained from chemotherapy or radiation. Neuralgic pain is sharp pain that follows the path of a nerve. Nerve damage often associated with disease, trauma, or medication. Something like shingles, trigeminal neuralgia. Body's response to pain: complex processes. Pain fibers become sensitized, psychosocial effects. Uncontrolled pain alters metabolism. Uncontrolled pain impairs immune function. Internal and external environment factors can make patients more susceptible to pain, and barriers that prevent adequate pain relief are barriers from perspective of a family or the patient himself, barriers from perspective of healthcare providers, and barriers from perspective of healthcare infrastructure. If we look at the lifespan and cultural considerations, infants and children less able to articulate pain can display behavioral responses. If you think back as to what we discussed in Nursing 100, we need to use pain scales that are appropriate for a certain age population. We talked about which ones would be appropriate for children. And if you recall, I think we talked about FACES pain scale are used with children age 3. Can also be used with patients who do not speak English. So, and think about how maybe an infant might display that they're having pain, crying, lethargy, maybe their blood pressure is up either high or low. Patients, maybe those children may be tachycardic or bradycardic, or maybe have periods of apnea, because obviously they cannot verbalize that they are having pain. Change in behavior is one of the best indicators of pain. Some 3-year-old children are able to give basic location and intensity of pain. Physiological considerations, obviously blood pressure is one that we look at. Untreated pain in children may result in decreased growth and development, affect their immune function, as well as lack of appetite, hypertension, and increased sensitivity to future pain, where they have that memory stored. That could provide a lot of physiological responses to that pain. Pain in adults: chronic pain widespread among adults, more prevalent among women than men. Women are more likely to develop pain-causing diseases, lowered pain threshold and tolerance. Men are more susceptible to pain from cluster headaches, coronary heart disease, gout, duodenal ulcer, and pancreatic diseases. And I'm sure you're more familiar with the pain kind of exhibited by our elderly populations. Most older adults have chronic pain. Physiological changes of aging affect perception of pain. Many of them are on so many medications, resulting in polypharmacy and drug interactions. Barriers to pain management for this elderly population could be due to inadequate knowledge of healthcare providers, fear of pain medication dependency, and noncompliance and financial barriers. Again, we talk about cultural and ethnic influences. What does pain mean to certain people in certain cultures? Variation in verbal and behavioral responses to pain, where cultures feel that pain is a sign of weakness. Culture plays a critical role in pain expression and management, and nurses have own attitudes, expectations, but must provide culturally competent care. We learned that in Nursing 100. The meaning of pain. Positive view of pain results in higher tolerance, decreases possible development of depression and anxiety about pain. Other considerations in regards to pain could be environmental and social support. Strange environment can compound pain. Lonely person without support network perceives pain as severe. Family education can positively affect perceived quality of life, caregiver and patient, expectations of significant others. Previous experience with pain, clients who have undergone procedures without adequate pain management, and patients who have seen a loved one suffer, maybe from a debilitating, deteriorating chronic disease. So that kind of sets the tone as how they perceive pain. Influences how patients perceive efficacy of future treatments. Obviously, as we are aware that patients who verbalize that they have pain, or maybe some objective data that kind of can clue you into seeing that your patient is suffering from pain. We watch our patient's vital signs. We use a pain scale and include pain intensity as that fifth vital sign. Observe and document verbal and nonverbal signs of pain and discomfort. Listen carefully to patient's description of the pain and advocate on patient's behalf to provide effective pain management. Administer analgesics per the instructions of the prescriber, and obviously monitor the response of that pain medication and monitor patient to determine effectiveness of interventions. And that's absolutely true, to make sure that we're helping our patients and we're not causing more problems with like respiratory depression or also ultimately to dependency. Educate family members about signs of reactions and educate patients about non-pharmacological pain management. Assist patients with self-care and teach patients and families about proper medication administration, side effects, non-pharmacologic methods of pain relief, and teach patients with acute pain about the expected course for healing. Teach patients with chronic pain about resources for home care, financial assistance, and support groups and counseling. So I think that does kind of summarize a little bit on acute versus chronic pain. As I said before, pain is an unpleasant sensory and emotional experience associated with an actual or potential tissue damage or described in terms of such damage. As I said, pain can be either physical or an emotional experience. Physical is a degree of a stimulus, and emotional pain can really depend on that person's mental status. And depression, we all know, makes pain increase, and laughter sometimes helps decrease pain. And pain is the result of actual tissue damage, or tissue damage may occur. Pain can be described consistent with McCaffery's classic definition: whatever the patient says it is, existing whenever a person says it exists. Depends on a person's perception of pain. As we assess further into our patient's pain, we want the location, intensity, quality, and duration. Sometimes just knowing where that pain is may help determine a person's primary problem. If they have back pain, could be that they're having a herniated disc. Chest pain after hip surgery could gear us to think that maybe this patient is suffering from a blood clot. Jaw pain could be considered cardiac pain. Intensity, we look at mild, moderate, and severe on a 0 to 10 pain scale. It can also correlate as to how a person functions, okay? And we talked about the many common descriptors and used to describe the quality. Burning, itching, tingling, cold, deep, aching, cramping, all those kinds of things describes the quality of pain. Pain, if we look at the physiological origin. It has to do with sensory and motor neurons, okay? I won't get into that. Your book kind of talks a little bit more about that in specifics, okay? Remember, there are different types of pain stimuli. Biological, meaning bacteria or viruses can cause pain. Mechanical, when we talk about pressure ulcers with shearing forces. Thermal, someone could get pain from extreme heat, suffering from burns, or maybe from the cold experiencing frostbite. Electrical can be burns, shock. Chemical can be radiation. Tobacco or cleaning solutions. There are a lot of pain theories out there. I won't really talk a lot about those. Those aren't going to be asked on the test, but your book talks about peripheral pattern theory, gate control theory. And pain can be classified based on the origin of the pain signal. Most nociceptive pain is temporarily unless the underlying cause of the pain is not treated. Neuropathic pain is caused by nerve malfunction or injuries resulting from trauma, disease, chemicals, infections, and tumors, and damage from either peripheral or central nerve damage. We talked about acute and chronic pain, and the different types or categories. And then just to kind of talk about breakthrough pain, a transient exacerbation of pain that occurs either spontaneously or in relation to specific predictable, unpredictable triggers. And then incident pain, predictable pain that accompanies a movement or activity. Say, for instance, if somebody has had surgery and they develop incident pain because they're doing some coughing or deep breathing, or maybe the person has to have a wound dressing done. Idiopathic pain is not associated with any known cause, and unpredictable type of pain lasts longer than incident pain. And think of those terms also in regards to phantom pain, where the body still senses that the limb or extremity is still there. Might be an example of a person who's had an amputation. Okay, they still feel like their limb is still present. Psychogenic pain is mental or emotional problems rather than by an injury or a disease. There's a lot of risk factors that may have a person have increased pain. Adolescents, people who are obese, patients who have type 2 diabetes, people that are going to have surgery, that pre-op anxiety, people that are more vulnerable to stress, things like that. I just wanted to kind of go over some of those important highlights from your assigned reading. Okay. There's going to be a couple articles that are kind of interesting in regards to pain. I think you're going to do those in lab, or you may have done them in lab this week. The article is Managing Pain in Frail Elders, and the other one is Assessment and Management of Pain in the Pediatric Patient. Very interesting to look at these articles and then just to talk about them, about, what issues that occur in elderly patients that contribute to the underassessment and treatment of pain. I think people think that older people don't sense that they have pain, and that every elderly patient is a dementia patient. Maybe sometimes it's only a matter of us being more aware of that. A different type of assessment needs to be done on a patient who is elderly, and knowing what happens in many of our elderly patients in regards to the aging process, what systems may be affected to cause that person chronic pain, and what are the effects that occur because of chronic pain. And then when we look at the pediatric patient, kind of on the other end of the spectrum, if a person or child cannot speak or describe pain, how can we assess that pain? in when assessing children in pain, what is essential pertaining to communication. So, and just what is the choice of pain assessment tool for children, and looking at the different pain skills, and are there other interventions than just pharmacological interventions to help people with their pain. So, very interesting to talk about that. And here's this Appendix 31, where, 36, where it's just a little exercise to do, where we look at acute versus chronic as we assess these patients, looking at pain location, the pain pattern, intensity, quality, associated symptoms, previous pain management, and how does this pain impact someone's life, and the patient's own beliefs about pain, and what are their expectations and goals in treating this pain. Just a little chart on acute versus chronic, and then doing this little exercise about examples of pain in your patients. Choose whether or not they're acute or chronic. And fibromyalgia is obviously chronic, diabetic neuropathy chronic, burns are acute, infection acute, fractured femur acute, sprained ankle acute, labor is acute, laceration acute, arthritis chronic, migraine acute, and cancer chronic, and low back pain chronic. And you could even see too, migraine headaches may even be chronic. People get them on a reoccurring basis. Okay? So, as I said before, those pain articles you're probably going to read in lab, or if you've not already done it today. I'm not sure if your lab was canceled today as well as your class being canceled this morning. I wanted to bring to your attention this WebMD pain topic website. It really does correlate with what we're talking about in regards to tips for managing chronic pain. And it provides 11 tips for living with chronic pain. And the first one is to learn deep breathing or meditation to help you relax. I'm not going to read each of these explanations of these tips, but makes sense. I mean, we do this for our patients who have respiratory problems, but deep breathing is a relaxing technique that really should be done in a very calming and quiet location, and that you as the person who is doing these deep breathing techniques should be very relaxed and in a comfortable body position to kind of block out anything that may be distracting you to try to relax. Let's see, that's number 1. Number 2 is boost chronic pain relief with natural endorphins from exercise. Remember, endorphins are brain chemicals that help improve your mood while also blocking pain signals. So exercise has another pain reducing effect. It helps to strengthen muscles, helps prevent re-injury and further pain. Number 3. Next page. Okay, I'm trying to think where 3 was at. Didn't get that. Well, number 4 is cut back on alcohol, which can worsen sleep problems. 5 is to join a support group. Meet others on how they deal. 6 is don't smoke. It can worsen chronic pain. 7 is to track your pain level and activities every day. 8 is to learn biofeedback to decrease migraine and tension headache pain. And then 9 would be get a massage for chronic back relief. And 10 is to eat a healthy diet if you're living with chronic pain. And then find ways to distract yourself from pain so you can enjoy life more. So, again, these are 11 tips for living with chronic pain. And if you can see too, you see on this left-hand side of the website how there are additional pain topics, how to live with foot pain, knee pain, migraine, things like that. So I thought this was very useful. So ways in which we can teach our patients, rather than always thinking that they need a pain medication to help reduce their pain level. I just want you to look at Appendix 38. It's just looking at 4 questions to just kind of think about things, where question 1 is about listing components required for an individual to feel comfortable. Consider more than relief of pain. And I think we talked a lot about this in Nursing 100, that sometimes it's about that physical comfort, that emotional comfort, and looking at your personal preference about what things make you uncomfortable. Are you uncomfortable if your hair is dirty? How do you feel if you haven't been able to get a manicure, take a shower, or trim your nails or facial hair? Or women who don't shave their underarms or their legs, how does that make you feel? Also think about making up a list that describes all the requirements for people to be comfortable, and then relate how you can incorporate this list into the care of your patients. And does culture affect this? And I'm sure it does. Because sometimes when we try to provide hygiene and comfort measures in that way, it might be very disrespectful to some people in certain cultures. So these are just questions to help you think about. And if we were in class, I'd kind of divide you up and have you think about throwing the answers back and forth to each other. But unfortunately, we're not in class, but I just wanted to bring your attention to this type of worksheet to make you think about what brings comfort, and not just about pain, which is very important, but it isn't the whole scope of everything. Well, all I want to do now is go over these practice questions versus acute and chronic pain. And these are downloaded again in your Canvas course. All right, let's just go over these questions. Like I said, you have these in your Canvas course. Oh, this is your PowerPoint. Let me bring up the questions, okay? I'm just going through this quickly, but this is another PowerPoint that will also help you pull out the important information from your assigned reading. I thought these were the questions. I'll pull those up in just a minute. This is a good PowerPoint. Pretty much is a basic outline from your reading. Going over this quickly. Okay. All right, let's go over these questions. A client indicates an intensity of 8 on the 0 to 10 pain scale. The best action for the nurses to take is which of the following? The answer is 3. Further assess the pain to determine the best intervention. And this will give you the rationale. I will post these on the Canvas course into week 5. Question 2, the nurse is evaluating a patient's pain. When documenting the pain, the nurse remembers that pain is... It's whatever the patient says it is. Very important statement. When describing pain, the patient states the pain is a dull, aching pain. The nurse determines that this description tends to indicate that the patient's pain is most likely the answer is visceral. This talks about what visceral pain is. Remember, it's deep pain from organs that I talked about earlier. The nurse is evaluating a patient's pain. The client states that the pain is at a level 2. The patient is indicating which of the following about the pain. Obviously, the intensity. I'm not sure if you'll know this, but I'll just go over with question 5. The nurse is aware that the A delta fibers conduct which of the following types of pain? The answer is sharp soothing pain impulses. All right, and this pretty much concludes our exemplar of acute and chronic pain. Let me know if you have any questions about anything I've discussed in this lecture, and I will see you all on Tuesday. Have a wonderful evening. Bye-bye.